What's up, everybody? Mike Ward here, and we are going live on the Longevity Game Podcast. All right. Hope everybody's doing well. Today, we're going to be talking about some good stuff. My specialty, we're going to be talking about testosterone. Testosterone replacement therapy. All right. How's everybody doing? Yeah, man, this is awesome. So we're going to be talking about some things that have been a big topic for a little while. For years, testosterone replacement therapy has been a hot button issue. And some people calling it life-changing, you know, other people warn that it's dangerous for the heart, you know. And that's been going on for a long time. Still people are saying, you know, like primary care providers or, you know, some clinicians are saying, well, don't get on testosterone. It's bad for the heart. It's going to cause heart attacks and strokes and all that stuff, you know. And so a lot of clinicians are being split down the middle, right? And so who's right? Like who knows? Who knows? Well, the largest and most important study or trial that we've ever had on this topic, called the Traverse trial, finally gave us some real answers, right? And today I'm going to break down what it showed, why the doctors were so worried in the first place, and what it means if you or someone that you know is considering testosterone replacement therapy. And so I should also mention, so I am the founder and chief executive officer of a longevity and performance practice called Next Level TRT. And so, you know, TRT is in the name, but we do way more than just TRT, right? So I'm going to be speaking from experience, not just somebody who just knows a little bit about testosterone. All right. I treat patients a lot with testosterone therapy. And I have seen big positive changes in people's lives who have low testosterone, and then we optimize their testosterone levels. It is a game changer for people. And so, you know, this topic is near and dear to my heart, right? So we're going to talk about this. But let's rewind a little bit. Okay, why were clinicians even worried that testosterone could hurt the heart in the first place, right? Well, first, there's biological reasons, right? Testosterone boosts red blood cell production, all right? And so that makes your blood really thick, right? And in theory, thicker blood means that you have a higher chance of clots, strokes, and even heart attacks, right? Hypothetically. And so testosterone can also cause fluid retention. And that usually happens whenever your estradiol levels climb, you know, but that is one of also another concern, right? It increases platelet stickiness. And all those things could strain the cardiovascular system, right? And so, second, some early studies, observational studies, suggested that testosterone users had more heart attacks and strokes. Although in these studies, they really never, that wasn't like their primary endpoint that they were looking at in these studies. And because of that, they did not frame the study in a way where they were actually looking for cardiac risk or stroke risk or blood clot risk, you know, stuff like that. And so, you know, we've had plenty of studies even before those studies in the mid 2010s, teens, that showed that it was very cardioprotective. And so because of these few observational studies, man, people just, you know, out of the idea of playing it safe, they just said, you know, we're not going to prescribe testosterone anymore, right? So these are small studies. They weren't very controlled, but they were just enough to raise alarms, you know. And in 2014, the FDA even put out a black box warning on testosterone products about possible cardiovascular risk that made clinicians extra cautious, right? The problem is many other studies actually showed the opposite, right? Just as I was hinting to, men with low testosterone had higher rates of heart disease, and men treated with testosterone sometimes had fewer cardiovascular events. So the field was stuck in this kind of like this paradox, right? The theory said it might be dangerous, but evidence often looked neutral or even beneficial, right? And so that uncertainty set the stage for the Traverse trial, right? And so what was the Traverse trial? It was really cool, and I'm really glad that they did it. It was a very long-term study, right? What did it look like? The TRAVERSE trial stands for Testosterone Replacement Therapy for Assessment of Long-Term Vascular Events and Efficacy Response in Hypogonadal Men. And so they recruited over 5,000 men ages 45 to 80 who had confirmed low testosterone, meaning they had both symptoms and 2 separate blood tests under 300 nanograms per deciliter. And importantly, these weren't like young dudes, right? They weren't like chasing muscle gains, right? These are middle-aged men or older men, many with already existing cardiovascular disease. And if I remember correctly, I think that you had to have some type of cardiovascular risk just to be in the study, right? And so these men were randomized to either daily testosterone gel or a placebo gel, and they were followed for about 3 years, right? And so doses were adjusted to keep testosterone in a normal range, and normal is that's arbitrary language, normal, right? Because normal is 300 to 1100, in most cases. But doses were adjusted to keep testosterone in the normal range, and then for safety, labs were checked regularly. And so in my clinic, I'll check labs every 90 days for the first year at least. And then after a year, I think it's important to continue to check labs, 2 to 3 times a year, unless there's something in the labs that come up that you're like, I'm a little concerned about that, And so in that case, we might check them a little more frequent. Okay, so what they found, the headline result is testosterone therapy did not increase major risk of major cardiovascular events, things like heart attacks, strokes, death from cardiovascular disease. About actually 7% of men in the testosterone group and in the 7.3% in the placebo group had one of those events. So basically, the same. There was no risk among groups or increased risk among either groups. They're about the same. And that's a really big deal. It means all this stuff. Testosterone's not the big bad wolf that we thought it was, right? When prescribed properly in men who truly need it, it doesn't make heart attacks or strokes more likely, at least over 3 years, right? Because the study was followed up in 3 years. It wasn't all positive though. And so we should definitely, cover, there were some things that we did find in the study where men on testosterone did have just a slight higher risk. But even then, there's just more studies that are being done now to kind of clarify, these findings too. So, one of the things that they found, the testosterone group had higher rates of some other issues like AFib, right? Atrial fibrillation is where your heart can kind of be irregular. It's an irregular heartbeat. Another thing is kidney injury. And so there was a higher degree of kidney injury. And then the last thing is blood clots in the lungs, also called PEs or pulmonary emboli. There was I can't remember how much, but it was like just 2 or 3 more men had pulmonary emboli that developed while in the testosterone group. And see, these weren't common, but they were more frequent, and so more frequent than the placebo group. So we can't ignore those things, right? Another important piece, the TRAVERSE trial also looked at men with prediabetes and diabetes. Some had hoped testosterone might prevent diabetes or even reverse it, but the trial didn't show any real benefit, in lowering diabetes or diabetes risk. It didn't stop prediabetes from progressing, and it didn't cause diabetes to go in remission, right? And so, what does all this mean? Is testosterone safe or not? I think it's important that, we keep an open mind. There's other studies that are ongoing right now. But first, the TRAVERSE trial, it does give us a strong reassurance, right? That testosterone's not, like I said, not that big bad wolf, it's not the heart villain, it was once feared to be, so doctors can now, they can prescribe it to men with real testosterone issues without really being scared or worried that they're going to dramatically increase their risk of, cardiovascular disease, heart attacks or strokes, Second, it's not a free pass, right? The risk of AFib, kidney disease, they remind us that testosterone is a medical therapy and it's not a lifestyle supplement. We still have to monitor things and keep an eye on those things. And I have to say, I've never seen an increase of risk of AFib. I've never seen any of my patients, and I have lots and lots and lots of patients. Nobody's ever, has ever experienced AFib. I've never seen a blood clot from testosterone replacement therapy in my practice. And I do see every now and then, I do see like a creatinine level go up or a BUN level go up, and these reflect kidney function. But also at the same time, some of these men are trying to optimize their lives. They have low testosterone. They get on testosterone. Now all of a sudden, they feel amazing. They want to get into the gym. They want to start getting healthy. They start having healthier, dietary and physical habits. And sometimes they eat a lot more protein. And, protein is, it actually can raise your BUN, and it kind of falsely elevate your BUN. As a matter of fact, it can also, if you work out a lot, you are constantly breaking down muscle, especially if you're weight training. Or if you take a creatine supplement, you can falsely elevate your creatinine level. And so, whenever, I talk to other clinicians about this, I mentioned, you can always get a confirmation test called a cystatin C, which will help confirm whether or not it is true kidney renal insufficiency, or is it just an effect of maybe he's taking more creatine, maybe he's working out a lot. These men who carry around just way more muscle mass are going to have higher creatinine levels. And then whenever you get, if you dig a little deeper, dive a little deeper, you find out like, whoa, that, they don't have any urinary protein. I mean, they don't have proteinuria, protein showing up in their urine. All their other markers that we drive, when I take a deep dive looking at kidney function, it's all normal, and so now I'm not going to say that it doesn't happen for some reasons. Like some people get dehydrated, and so people don't drink enough water. People are actually working harder now, maybe they're, sweating more, they're becoming more dehydrated. And that can also cause renal insufficiency or cause your creatinine level to go up, your BUN level to go up. So if you're a clinician and you're watching this and you're just starting to work with, people and, prescribing testosterone and treating testosterone, if you're ever concerned at all, I would highly recommend you just refer them to nephrology and they can figure that out. All right. So I know I'm kind of ranting about, ranting and raving about the creatinine issue and the BUN issue or the renal issue, but, that's, you only get 2 kidneys and they're not giving those suckers away. So I would pay very close attention to that. But out of all the other things that they saw, either the AFib, the blood clots, and the renal problems, the only thing that I've seen close to any of that is mild renal insufficiency that possibly might not be. Once I get a confirmation, a cystatin C test, most of the time it's completely normal, or they just need to drink more water and everything clears up after a month because we get labs, follow-up labs. But that is definitely one thing that you don't want to mess around with. Refer out to nephrology. But third, so back to what we were saying, third, I think we were on 30. It's not a cure-all, right? Testosterone replacement therapy won't magically fix diabetes. It won't make you live forever, and it's not meant for men with normal testosterone who just want an energy boost or just to build muscles, right? Although there's a lot of people that use testosterone just for that, right? The Traverse trial only tells us about men with confirmed deficiency. And then finally, remember the time frame. Traverse followed men for about 3 years, and that's reassuring in the short term, right? But we don't know for sure what happens after 3 years. At 10 years, at 20 years, we're not sure, and so I don't know for sure if there's a long-term study going right now, but those are things that we need to consider, right? And so that's what, there is ongoing research, but I'm not sure, how long those studies are. But also careful clinical judgment still matters, right? So, that's the Traverse trial. And I'm not trying to scare anybody because testosterone replacement therapy, like I said, is a game changer in men with low testosterone. And I sometimes, after I'm sitting with a patient and, I think about, all the men out there that just go through life thinking that, yeah, this is just how I feel now, because I'm getting older, and they don't even consider getting their testosterone checked. Or maybe they go to their PCP and they say, nah, you're fine, you know? And I just wonder how many guys out there are just dealing with life, feeling pretty blah, and all they got to do is get their testosterone checked and then get on testosterone if they need to have their testosterone optimized. It is absolutely life-changing, you know? So anyway, the next time somebody asks, is testosterone dangerous for the heart? The answer is not in the way we thought, right? So the Traverse trial showed no extra risk of heart disease or heart risk, no increased risk of strokes, heart attacks in men with truly low testosterone, but it's not risk-free, right? And so it's not for everyone, right? It should always be prescribed by a qualified clinician, not bought from these underground labs online. And you want to do that with monitoring, right? You want to make sure you're monitoring your testosterone levels while you're on testosterone replacement therapy. But not just that. There's a whole bunch of labs that you need to be watching. You need to have a CBC checked because your red blood cell count can be affected by testosterone replacement therapy. You want to make sure you're getting your estradiol checked, right? Your estrogen levels are going to go up while you're on testosterone, which is fine. Estradiol isn't a bad thing. You know, as a matter of fact, there's a lot of misperception about how estradiol affects men. But, you know, estradiol is important. And when you get on testosterone, men convert or aromatize testosterone into estradiol. And it does that because that's what it's supposed to do. And if you have higher testosterone levels because of your testosterone replacement therapy, you're also going to have higher estradiol levels, right? The problem may lie in the fact that whenever it gets too high, you may have estrogenic side effects. And so there's two lines of thought with that. Are we going to deal with those estrogenic side effects? I do. But only temporarily. You know, I will knock the estradiol down just a little bit for a very short amount of time if they're having estrogenic side effects and their estradiol level is high. And when I mean high, I mean like 80 or 90 nanograms per deciliter. I don't typically do anything with it if they're not having any estrogenic side effects and it's that high either, you know. So, but it's super important. It plays a big role in a lot of things, you know, and I've talked about a lot of that in the past. But, you know, if you think about a woman who goes through menopause, her estradiol levels tank, right? She's not making estrogen anymore. She has an increased risk of Alzheimer's now. She has an increased risk of cardiovascular disease now. She has an increased risk of visceral adiposity, which is fat accumulation around the visceral organs. She has an increased risk of osteoporosis and fractures. I mean, men experience all that too whenever you take their estrogen away, you know, and they also experience severe sexual dysfunction. Man, if you crash a guy's estrogen, he will not be able to get an erection. All right. I mean, it's important, right? So anyway, there's things that you have to watch. Another more labs that I get, I check a PSA just because I think it's important. I check total testosterone, obviously. And then I also check like a CMP, a comprehensive metabolic panel. Yeah, those things are going to be moving and fluctuating with testosterone replacement therapy. So you want to be sure that you're getting those checked out, right? So testosterone therapy isn't the enemy, but it's also not a magic bullet. It's one part of the toolkit, guys. It works best when it's paired with lifestyle changes, nutrition, exercise, sleep, and even stress management. All right, so that's about it. I think we're pulling about 20 minutes now, and yeah, I think that is the heart of the story. So you guys have a great day. I thank you for joining, and if you are interested in being a guest on the Longevity Game podcast, just go to Be a Guest. Email me at beaguest@thelongevitygamepodcast.com. If you are looking to sponsor the Longevity Game podcast, then go to Be a Sponsor at thelongevitygamepodcast.com. If you are a viewer and you have questions, concerns, or you just have something you want to share with me, or you got a suggestion for a topic that you like for me to cover, go to hello. Send me an email at hello@thelongevitygamepodcast.com. If you're watching here on YouTube, I'd ask you to consider subscribing, leaving me a comment. below. Give me a thumbs up or a like and all that stuff, and share it with your friends. All right, everybody. I appreciate you for hanging out with me, and I hope you guys have a great afternoon. Yeah. See you guys.